Welcome. My name is Dr. Chris Linas. I'm here on behalf of AlphaCore DX, and I'm going to introduce a phenomenal guest in a moment. But prior to that, this topic is about cancer, cancer in America, cancer around the world. It's very pervasive, as we all know. And there's 5 basic screening tests that we all are familiar with: mammograms, colonoscopy, stool tests, CT scans, which are x-rays, of course, of the body, doing the PAP, which no one wants to do. And then the second thing no one wants to do is getting the finger from a prostate exam and a PSA. So there's these tests that we can do, but 71% of cancer deaths are related to things that are not routinely screened for. And so we're going to speak to an expert in this field in a moment. But what's exciting is Grail, the company Grail, has a test called the Galleri test. And the Galleri test, with a simple single blood draw, can measure for over 50 different cancers from a cell-free DNA marker perspective. So on that note, I'm going to actually do some Q&A with Dr. Whitney Jones. He is a gastroenterologist. He's an educator for Grail, and he's going to talk to you about the Galleri test, which I'm excited about. I already have set up an account in my clinical practice to start doing this test for my patients, because up to this point in time, I did not have, nor did anybody have, access to this kind of testing to help eliminate the question mark that we all have. So Dr. Jones, welcome.
Hey, Chris, great to be with you today. Thanks for having us.
Well, thanks. So I mentioned all the screening tests we're familiar with as docs. So are there limitations that people want to know about on these screening tests? We're not going to ever dismiss these screening tests. We all know they're important screening tests, but I believe that Galleri offers something in addition to that. Maybe we can start with that question.
Yeah, well, I'd start off. The peak of cancer mortality and incidence in the United States was 1991. And we've been making steady progress since that time. Part of it from therapy, part of it from improvements in lifestyle, particularly smoking. But the third one are lives saved from early detection programs for very common cancers that you mentioned. And so those tests work great. They are absolutely supported by rigorous data. But as you alluded to, it only covers about 3 out of 10 cancers. So 7 out of 10 cancers, either people don't qualify for screenings or those cancers are unusual enough that it's impossible to screen populations for rare and infrequent cancers. And so what's really happened in the last couple of years that's led to the Grail company and the Galleri test is that we've been able to leverage machine learning, which is really high-powered computing, along with improvements in DNA sequencing technology called next-generation sequencing, to where we can literally find that needle in the haystack, not rarely, but on a regular and predictable basis. And so what's really happened is that belief that early detection in cancer helps save lives, as well as give a person a better opportunity. Now we can expand that from 30% of cancers to all cancers.
Wow. And so with a simple blood draw, and this blood draw is measuring what exactly?
Well, what we're looking at are markers in your blood that reflect changes in your DNA that are associated with cancer signals. And DNA 101 is just a quick primer. We think about what we inherit from our parents, like a BRCA mutation or a Lynch syndrome. That's the germline mutation. You inherit that, that's in your DNA code. Once a person gets cancer and they check the cancer to see if there's any weak spots that allow for better precision oncology and therapy, that's called somatic mutations. And that's an after the cancer fact. What we look for is right in the middle of those two, in front of the oncologist's door. And we're looking for changes in the patterns of methylation in your DNA, because it's fascinating. Your eye cells and your leg cells have the exact same material in their chromosomal pattern, but they do completely different things. And the reason for that is methylation patterns drive what happens in your cell and what gets turned on and what gets turned off. So by using methylation, it's an incredibly impactful and accurate way to find signals in your blood that are associated with cancer. And we can go into what those original studies were like, but it's a DNA test unlike the two that we're most familiar with in practice right now.
Wow. That explains a lot. Clearly, we have the benefit of this technology. In my clinical practice, I talk about the importance of methylation all the time and gene stability. So that's just beautiful. So I'm over 50. As a result, I'm at a higher risk, and there's other comorbid factors in addition to people over 50. If you're a smoker, you have a personal history of cancer, family history, as you mentioned, germline. If you're immunosuppressive states, either you have a bone marrow suppression, you're on a organ transplant list, or you've been, of course, transplanted, obesity, environmentals, first responders, which I'd love to hear a little bit more about, and veterans. So maybe talk a little bit about these comorbidities. So over 50, being overweight, and first responders and veterans, question mark?
Yeah, well, I think that the key thing that you brought out is that Galleri is a test designed for people at an increased risk for cancer. And the easiest way we identify that risk at a population level is just age. People who are over 50 are 13 times more likely to develop cancer than those lucky enough to continue to be under 50. And so what we really do is talk about that elevated risk. But there are people under the age of 50 whose risk might be similar to that 50 and above population. And you really went through those. And right now we know they have similar risks. There are studies around the Galleri test trying to understand those risks and how Galleri looks in that. But the take-home message is if you're at an increased risk for cancer because of your age, personal habits, family history, environmental exposures or acquired abnormalities such as immunodeficiency, it may well be that the Galleri test is appropriate for you under the age of 50. And that's an informed decision you need to have with your provider to understand, how that test performs and how it could be right for you.
I think that's brilliant. And a first responder and veterans, they were on the list of higher risk. Is that because of what they get exposed to?
Well, I think that certainly their exposure is the primary driver. Otherwise, they still have family histories and personal habits like smoking or whatever. But firefighters, for instance, and we have several programs going on around the nation with firefighters, they have a 15% increased risk of cancer over non-firefighters. And this is not only from the fumes that are exposed to, some of it has to do with exposures in the firehouses with diesel trucks running all the time. The chemicals get in their clothes, it gets in their bloodstream. It takes them hours, days to off vent all of these chemicals. And I would assume that there are probably going to be similar exposures in the military. Again, you hear about these burn pits that have occurred in certain areas. Again, that's the middle of the fog of war. It's difficult, but we provide our veterans with a lot of coverage and protection. And interestingly, we're just starting the first of 10 sites studying the Galleri test in the VA system across the country. And the first one will be in Pennsylvania. So yes, all of these people are on our list for those at high risk.
And that's awesome news, because I also think there's probably a huge amount of stress, obviously, with the first responders and clearly veterans, current vets, and also PTSD and all the stress that they carry on for a lifetime. So in terms of the frequency of running a Galleri test, annually, we want to be proactive. We don't want to end up being reactive, and we want to do a societal investment. This is about really taking charge of our health. We know that statistically, toward the last year or so of our life, we can spend all of our lifetime's earnings on trying to play catch up on health matters that maybe were not attended to and so forth. So let's talk about the societal investment and proactive medicine.
Right. Well, I mean, certainly not only is cancer difficult, but cancer is financially toxic. So let me just start by saying, who's the Galleri test not for? Well, number one, if you're under 21. Number two, if you're pregnant. And number three, if you have cancer, but you're within 3 years of that cancer diagnosis and successful treatment. So after you're done in 3 years cancer-free, the Galleri test rolls right back into it. And so when we look at that, those are the groups. Now, what's the interval? Right now, we see the Galleri test as an annual interval test. And a lot of that is because the most deadly cancers, which we happen to identify preferentially over indolent cancers, have what's called a very short dwell time, meaning they can go from a stage 1 cancer to a stage 3 cancer literally in months or years. So our best chance for catching those most aggressive cancers is to check that on an annual basis. Certain cancers like thyroid cancers or prostate cancers go years and years and years. And again, have a different performance, characteristics, because again, we don't preferentially identify benign, slow growing tumors. So we don't tend to overdiagnose. We do tend to more actively identify aggressive tumors. So right now we see it at a 1-year interval, but certainly we know it works at a 2-year interval when it's modeled. It's just that we pick up less cancers, and the cancers we do pick up are a little more advanced in stage. So I think over time we'll understand those intervals across different levels of risk, as well as just the average risk person out there in your audience.
Yeah. And the analogy I make with my patients, if you think of the lawn that you mow on a weekly basis, but then you mow the lawn and it's grown X amount, but the weed, the dandelion, is gone to almost blossom within that same period of time. And that's really like a cancer cell. It's a weed within our beautiful trillions of cells of our garden, and routinely maintaining that so they don't disperse themselves. It's kind of an analogy I make.
That's a great analogy. And I want to do another little analogy, because I think it's really critical. And it's about multi-cancer versus single cancer screenings, right? And I spent the last 20 years of my life dedicated to single cancer screenings in colon cancer space. But what we do right now with screenings with the 5, and we'll just include prostate, is you have to take a day out of your life, go to a different place, use a different type of technology to screen for one single cancer. And since they're based on high sensitivity, that means they have relatively lower specificity, which means a lot of false positives. And so, for instance, an abnormal mammogram is only, showing cancer really about 5% of the time, 1 out of 20. Most of them are not. Our study is a little bit different. Number one, we're not based on high sensitivity. We're based on high specificity, meaning that if your test is positive, the likelihood that you have cancer is very high, 10 times higher than any of our current screening tests outside of colonoscopy, which is an index test. So the analogy is, instead of going to 5 different places each year to do these screenings, you can go to one place, look at over 50 different cancers, because we try to find a common cancer signal first. And then once we find that common cancer signal, we try to identify where that cancer came from. So rather than going to all of those places, we're able to actually do all of this in a single test. That being said, those tests are set up the way they are for a reason. Those cancers are common and they need high sensitivity. So the Galleri test is a complement to the current USPST screening test, not a replacement for it. And that's really critical for your audience to know. Just because they get a Galleri test and it looks good doesn't mean that we want them to skip their colonoscopies or their stool testing or their pap smears, because those have both prevention and early detection. And likewise with mammography, such a common cause. We've made such great headway amongst women's health. Critical to maintain those routine USPSTF screenings.
And I fully agree. Yeah, continue doing the regular screening, but each of those screens are measuring one little body part. And this is a much broader view of the racetrack or the playing field of what might be going on. So you can be highly focused on breast or prostate and colon, but totally miss what else is going on in the field, which would have made the highlight reels in the greater scheme of things. So
for sure. And our test functions in that some of the screenings that we look for in USPSTF, our sensitivity is lower in some of those, versus in the more aggressive cancers like lung, liver, pancreas, ovarian, esophagus, we have very high sensitivities. So they do really work as a complement to each other for the wellness of your patients.
Yes, and it's beautiful. This is near and dear to me. I lost my father. He had 2 cancers, and he had bladder and prostate. And my mom had metastatic lung cancer, just lost her here in April. And the reality is, cancers prior to my parents, we had no family history of cancer. Now I have a family history. First, it was my father. I said, great, now I have a family history. But the reality is we live in a much more toxic world. We live in a world where there's more foodstuffs. As they say, the foods on the average grocery store weren't around a generation ago. These are all foodstuffs, and we have a more toxic chemical world. And so obviously this is something near and dear, and this is why I'm so excited to speak with you, Dr. Jones, on the topic. And so along with the methylation and DNA, I was the dean at the oldest naturopathic university for 7 years. We focus on wellness. So when a person gets the report back, obviously their healthcare provider will get the report back, or if you're working with Alpha Core DX, we'll get the report back and you'll work with a doctor to understand it. what will they be looking at when they get the report back, and what might they ponder diet wise, lifestyle? So let's say they're normal, and what percentage of people will come up with a positive?
Okay, it's a great test. And again, remember, we are designed to have very high specificity, which means very low false positive rates. 5 in 1,000 are going to be false positives. And so when you look at how the test reports, again, I want to reiterate this because it's a two-part test from a DNA standpoint. The first is, do you have a common cancer signal? Yes or no? The vast majority of people at any one time don't have cancer. It's about 1.2% per year. So the vast majority of people with no cancer get a negative result. So 98 times out of 100, the result is going to be no cancer signal detected. The negative predictive value of that is 98.4%. So with a negative result, you can be 98.4% sure that there's no cancer. And as I said, the ones we tend to not pick up are ones that are more indolent and slow growing and less aggressive. About 2% of the time, and right now we're tracking about 1.3% nationally, but just for ease of that, you're going to get a cancer signal detected result. And what that means is we've detected patterns of methylation in your blood that are consistent with people who have cancers in their body and also in their blood. So if your cancer is not shedding cell-free DNA, we can't pick it up. Some cancers shed 0, some shed on any type of a scale. So when you do have that positive screening test with the Galleri, it means that you need to undergo a diagnostic evaluation to either confirm or to refute that you have cancer. The way our classifier works on this second part is that there's a confidence of where that signal is coming from. And that, by the way, comes from methylation. Because again, methylation is what tells your muscle cells to be muscle cells and your kidneys to be kidneys. So there's a fingerprint of methylation on your DNA, and that's what we use and take to our advantage to decide it. But we're only accurate about 9 out of 10 times when a cancer is present. So there may be cancer present in your body, even if it's not in one of the 2 signals that we provide. Some common places where it makes mistakes are HPV-associated cancers, human papillomavirus, which causes anal cancer and can cause cervical cancer and can cause head and neck cancer, a la the Michael Douglas piece that we went through.
Yeah.
Some of the other places it makes confusion areas are with organs that are of similar embryologic organ, like fallopian tubes and ovaries and endometrium, all come from Eulerian origins. The foregut, which is your esophagus, stomach, part of your duodenum, your liver, pancreas, those can all have shared signals. But the key thing is understanding how that test works and then focusing in a directed workup to identify the cancer. And this will be one of our challenges going forward because we're not used to seeing stage 1 esophageal cancer. We're not used to saying stage 1 pancreatic or stage 2 disease. So we're going to have a real heightened sense when we look through these imaging studies and we determine what have we ruled out conclusively, that we do a careful job. Because we're not looking for stage 4 pancreatic cancer when we're looking for a pancreatic cancer signal. We're looking for a stage 1 or a stage 2. Stage 3s are easy to find. Stage 4s are easy to find. This is all about moving and shifting that backwards. So we're going to have to be careful as a medical community and a medical, team to really make sure that we have sorted through all those possibilities before we declare it's truly a false positive. And in that case, when it is a false positive, excuse me again, we're going to need, I think, to follow those people closely, because if they have those methylation patterns that are present, certainly if there's no cancer present right now, and there's a couple of reasons why, cancer might not be detected. Number one, it's a true false positive, right? There's no cancer. Number two, it could be cancer in a different location. That's why we have to have that broad look.
Yep.
Or there's always the possibility there's a cancer below the level of detection. And that's why we offer patients with a positive Galleri and a negative workup a free retest within 6 months to sort of evaluate that signal course. But again, I think even then, if it's negative, we're going to follow those people more likely closely over the next several years because of that risk that methylation imparts.
And I want to speak to the methylation because methylation is something I wish everybody knew about. we have certain methyl groups, a methylfolate, which is a special kind of folic acid. We have B12 methylcobalamin, and we have a methylation process going on. As you point out brilliantly, we are turning on and off our genes. Why is my lip gene not pulsating like a cardiomyocyte? Because that particular portion of that DNA is saying, no, you're a lip, you're not a heart. But now all of a sudden, when we take away that methylation, all of a sudden it's like, I wonder what I can become. And we don't want our cells to do that. So this is why AlphaCore DX has chosen to offer the Galleri test. We also offer DNA tests that also look for methylation weaknesses within the body, because not everybody's created equal. Some people are better methylators and some are poorer methylators. Can you speak to that?
Well, I'm not really an expert in, methylation, outside of saying that when you are exposed to a variety of environmental issues, certainly personal health issues, obesity, smoking, dietary issues, it absolutely impacts us. And I think that one of those final common pathways is methylation. And so again, in our studies, we use people with known cancers and look for those methylation patterns in their blood and in their tumors to be able to train a classifier to identify a pattern of methylation that's associated with a cancer signal. But in terms of that lifelong piece, I mean, we're probably never healthier than when we're babies. And from that time on, father and mother time, have their way with us. And at the end, we're probably just one methyl group when we fizzle through the environment, I guess.
Yeah, and I think the beauty of what you explained relative to the screening is if it's positive and you get worked up, you get a free follow-up on the testing within a 6-month window of time, which is a commitment saying, hey, we really believe that there's something you should keep an eye on, because it might be a smoldering ember and it might be showing up stronger. And as you point out, if it's in the female reproductive area, it's like, okay, did you look in all those areas? Or is the microscope, is our ability to see it with this very early detection sufficient? But now all of a sudden it's showing up a little bit more as the weed in the lawn, and now it's detectable. You go back to your provider and they can now identify and refocus, and now it's more visible. Would that be fairly accurate?
Oh, I think that's 100% accurate, because I mean, we certainly know that all of the screening tests we use right now still test for colon cancer, mammograms, pap smears, lung cancer, CTs. Prostate's its own sort of world over there with lots of things. We all know that they have false positives and they have false negatives, that, there is no such thing as a perfect screening test. And likewise, the Galleri test is not a perfect screening test. It has false positives, it has false negatives. It's important for people to know how its performance is. For instance, it's not to be used as a single cancer test, right? If you happen to be really worried about prostate, this is not the test for you, because our sensitivity in prostate is low because it doesn't shed DNA into the blood. And so this wouldn't be that test. This is really, like I said, it's like dragging that net through the ocean of cancer, increasing and adding to the good screenings that we already have available. It's just another layer of protection. One way of thinking about it, when you look at a population level, we pick up about 200,000 cancers each year with all of our screening tests that we do right now that are recommended. We have to sift through about 7.3 million false positives to get there.
Wow.
The Galleri test is going to add and pick up another 427,000 cancers, so almost tripling our cancer detection rate through screening, and only add another 740,000 false positives. And I'm sorry, I think that's 8.3 million false positives, even worse. So we live in this world right now where we accept the false positives. We accept the workups that go with them, because the chance to find that cancer earlier when it's more treatable and more amenable to cure is worth it. And what Galleri is, I believe, is a broader and also more efficient way of expanding that early detection paradigm.
And I agree. And what I believe, if I had a magic wand I could wave, is everybody would get this test that's over 50 or has some of these other risk factors. And then I believe that all healthcare providers should be offering this test, whether they be the standard MD or DO, Chiros, naturopaths, and other individuals. But I think the reality is not all practitioners are going to be willing to do it or adapt. They're slow adapters and they don't adopt as well. So this is why, of course, AlphaCore DX is offering it direct to the consumer through a healthcare provider. So this paradigm shift is huge. Catch it early, deal with it before that proverbial dandelion goes to seed. So
no, you're right. I mean, this is going to change the way we do medicine, and to have lived long enough to see a new way that we can detect cancer signals and preventative during my lifetime, I think is amazing. I'm not sure I ever thought I'd really see it, but in fact, it's here. And in terms of the system that you're talking about, I think, there are different doctors have different levels of evidence that are okay with them to do it, right? Early adopters are in one space. I think the key is if this technology makes sense, and even though we're like the first iteration of the cell phone, we're still a cell phone versus a landline.
Yes.
And so I think once you've made that jump, then I think it makes good sense, like we do screening for other things like blood pressure. You don't pick and choose who is appropriate for screening. You make sure they're all aware of it and they all have that choice to make individually, because the reason you screen for blood pressure is, heck, I can't tell by looking at you if you have high blood pressure. And so that's why you have to take the person's blood pressure. So I think this really, at the primary care level particularly, something that your patients need to be made aware of as part of your system, your cancer prevention system. Certainly it's up to them. Right now it's a cash pay price. And so I think we're in a bridge moment from the new tech innovation to where I think we see ourselves, and we want to be following those guidelines with FDA and CMS, to where this becomes a more broadly available, covered through insurance test, where again, that threshold of getting over the initial cost isn't really a barrier anymore. Rather, it becomes something that's there. But that's our vision for it. And again, we know there's lots of regulatory agencies, and we are in line with all of them on following their prescriptions and recommendations. But the reason we came out with this and offered it as a lab developed test right now, while we're working on those, is because we lose 600,000 people every year in America to cancer, 1,700 people a day, the same as the number of people that died from COVID on an annual basis. And we think that this technology has the opportunity to really change the shape.
And I fully agree. And to kind of wrap up this, the Galleri test is only offered by prescription through a healthcare provider or partner companies like AlphaCore DX, where you can access it if your healthcare provider is not able or willing to order it for you. And I always tell people, you're not just taking care of yourself, but you're also taking care of everybody that loves you, cares for you, needs you. And catching something early is ultimately the way to go. It's that proactive versus reactive, and trying to play catch up to an avalanche. And we can't prevent things in totality, but we can catch things early. And if we can catch things early, why not?
Yeah, I mean, as I said, cancer is it's not a certain thing we'll be facing, but quite close to being certain, right? Over half. By 2030, the number one cause of death in America will be cancer, not cardiovascular disease. But just like cardiovascular disease began to focus really hard on prevention over the last 50 years, this allows us to focus more on early detection. And it's not that we just decided today was the day to roll it out. We never had this technology available to us before. And thus, what I would consider is that sense of urgency to get the word out, to make sure people are aware, let them do their research, let them work with their physicians to get to these answers, make their own decisions. But this test is there, it's available today. And that's what this podcast is all about, is making sure people are aware of it.
Exactly. So thank you, Dr. Jones. Phenomenal. And I just appreciate your time and sharing with the AlphaCore DX community and the entire world what you do. I've heard your travel schedule, and thank you for traveling so much and empowering doctors and healthcare providers and the public as well in this podcast to know this test is available. And now the question is committing to doing this on a regular basis annually, and then take care of yourself, because you're special. And that's why I'm speaking to the audience. You're special, and you need to take care of yourself, safeguard yourself.
Well, Doc, you're special too. We really appreciate the time to be able to talk about our paradigm shifting assay. And I think we'll look back in a decade from now and say, how did we practice medicine without this?
Exactly. Amen. Well, thank you, Dr. Jones.
Bye-bye, Chris. Such a great pleasure. Thank you.
Thanks.